Good morning, everyone, and welcome to our Friday morning virtual program. And we have the honor of having Dr. James Wu, who has gotten up incredibly early to join us from Los Angeles. Before we get started with that, I just want to call your attention to Thyroid and really to encourage all of you to take a look at this new platform. What it is a introduction to international thyroid cancer and thyroid nodule guidelines that have been distilled into a format that is much more easily accessible and much more easily usable on the front line. This platform will continue to evolve and to add more and more information over the course of the next several months as we introduce medullary thyroid cancer and anaplastic thyroid cancer guidelines to it. So we welcome your feedback and encourage your taking a look at it. But this morning's program is on a slightly different but certainly related topic, and Dr. James Wu, who is assistant professor at UCLA. He is an endocrine surgeon who originally trained at UCLA and then came to the East Coast, where he found out exactly what he should be doing in head and neck oncologic surgery when he did a fellowship at Memorial. He is both a researcher as well as an active surgeon and serves as the social media editor for Video Endocrinology and has a podcast or is involved in a podcast called Beyond the Knife, which I must admit I have not tuned into, but I will certainly have to do so now. So with that, as always, I encourage all of you to send in your questions, which we will try to get to before the end of the hour. And James, I'm going to turn the program over to you, and thank you again for joining us.
Thank you, Mark. Good morning, everybody. So thanks for having me. Today I'll be talking to you all about what we do for preoperative imaging for thyroid cancer before surgery. I don't have any disclosures, with the exception that I'm not a radiologist, but I am a surgeon. So the talk will probably be heavy on the clinical implications and a little bit lighter on the radiographic findings. So today, of course, we'll spend most of the time talking about our workhorse, the neck ultrasound, but I'll also quickly talk about the role of cross-sectional imaging and a quick note about flexible laryngoscopy. All right, but let's start by talking about neck ultrasound. So in just the basics, and those who aren't doing this themselves, I think I want to make a quick plug for the ease of use to get our own images. The best way to do it is to have the patient hyperextend their neck. We have a multitude of good ultrasound machines that can be really made available in the clinic. There's always a number of probes to use: the phased array probe, curvilinear, linear. The best one for thyroid imaging is going to be the linear probe because it allows for the highest frequency ultrasound waves. There's a trade-off between probes where as the frequency increases, it can penetrate the tissue less, but gives you the highest resolution image. Because the thyroid is superficial and we want the highest resolution, the linear probe is going to give us the best view. I think we're all very familiar with what we're looking at when we look at neck ultrasounds. You're looking for the size of the nodule, echogenicity, the shape of it, calcifications. Instead of talking about the individual things that we can note on ultrasound, I think there has already been many efforts about funneling all of these findings into reporting systems that help us broadly categorize the risk of malignancy. And so instead, I just want to talk about those reporting systems and about which ones we should be using to assess for the risk of malignancy to lead us towards surgery. So broadly, I'll just talk about the two main ones. The first one is the ATA classification system. Again, this is something that is a great resource. The ATA separates it into these categories where they talk about the suspicion of cancer. And it's really based on the imaging findings on the ultrasound. And it's great because in the guidelines you can find that there are these pictorial representations, and the guidance is that for low suspicion lesions, you can biopsy them if they're greater than 1.5 centimeters. For anything that's intermediate or high suspicion, the recommendation from the ATA is to biopsy them if they're over a centimeter. Very low suspicion, anything over 2 centimeters. And then everything that looks benign or under 1 centimeter, no matter what it looks like, recommend against FNA biopsy for further workup. The one major downside of the ATA classifications is that they exclude a number of imaging findings that we can see, including the ones listed here. And so up to 10–13% of lesions when we ultrasound them won't fit into under one of those categories for guidance. And also they talk about lesions being partially cystic, but nothing describes how cystic is something to be partially cystic or solid. So any amount of cyst to a nodule makes it partially cystic. I think this adds a little bit of ambiguity to the ATA system and makes the reporting less universally understood. The other one I'll mention is the Thyroid system by the American College of Radiologists. So this system, the benefit of it is that it's set into these 5 broad categories. Each one gets a score, and I think the score allows us to score every kind of nodule, so none are kind of left out, unlike the ATA. It's based upon the composition. There are some examples there of something that is cystic, that spongiform appearance, and then anything mixed cystic solid or solid. There's points for the epigenicity of the nodule, which you can see some examples there. You get many points if the nodule is taller than it is wide. Look at the margins and about the type of echogenic foci that are in the nodule. And this covers the rim calcifications that the ATA guidelines leave out. And what's also great is that you can see that the threshold for FNA in terms of nodule size is a little bit higher and more robust for the TIRADS 3, 4, and 5 categories. And so this paper published in JCE&M looked at both those 2 main categories, the TIRADS and ATA classification systems, as well as 3 others. And comparing them head to head, if we just look at the number of biopsies avoided, meaning that all these nodules finally underwent surgery, and they looked at the number of benign nodules that were also called benign or likely benign on imaging, and thus those could have been avoided even getting an FNA biopsy. And you can see that in the TIRAD system, you had the highest percentage of patients that could have avoided FNA biopsy because the ultrasound findings are so benign. And then we can also see that the sensitivity of these 5 systems, that the highest sensitivity is the Korean TIRAD system, but because they are so aggressive about trying to capture anything that could be malignant, that their specificity is very low at 17%, and that the TIRAD system has relatively equivalent at 83%, with the highest specificity at 56%. Overall, the TIRADS gives you the lowest false negative rate, allowing you to avoid biopsies by using that system. All right, so those are mostly reporting systems to talk about looking for the possibility of cancer. But now let's talk about once we already have the cancer diagnosis, or that when we've chosen surgery for a suspicious nodule, what are we doing with our imaging? For neck ultrasound, in the surgeon's hands, I think that we're really only looking at these two main aspects once the diagnosis has been made. And that's whether there is extrathyroidal extension and looking and mapping out the lymph nodes in the neck. And the reason why is because we are just trying to determine with those two aspects, what is the extent of the initial surgery that we need to perform to clear disease. Obviously, we want to do as the least possible with the lowest surgical risk to achieve a good resection. So, of course, things that would make you want to do a total thyroidectomy instead of simply a thyroid lobectomy, which is size greater than 4 centimeters, easily seen on ultrasound. I think that size criteria is a little bit of a soft indication. Any extrathyroidal extension into the strap muscles, and then bilateral nodules. It's really important for us to have high sensitivity for any nodal involvement, because we also want to be able to perform any neck dissection, whether that's central neck or lateral neck, at the time of the initial surgery, instead of having the patient come back. And then, of course, we always want to have a good idea on imaging whether there's any major gross extrathyroidal extension into the aerodigestive structures, anything that would require even more involved surgery, such as tracheal resection or laryngectomy. It's always tough when you find yourself seeing invasion to the tracheoesophagus when you didn't plan on it, because you didn't know from your imaging. So let's talk about what we need to make sure we get all those pieces of information before making that first cut. All right, so extrathyroidal extension, something that we can easily see on ultrasound. These are some examples here. We'll go over some of them in detail. One of the ones you can easily see is when there is abutment and then a blurred margin anteriorly between the overlying sternothyroid muscle or sternothyroid muscle and the lesion itself. On the trachea, what you'll, instead of seeing a blurred margin, is more of this very wide, flat footprint, and that will suggest the possibility of extrathyroidal extension. And then posteriorly, same thing, you can see an irregularity and a fuzziness to that posterior margin that would suggest ETE. So the real question is, those are the obvious examples, but I think there's always going to be a question in surgeons' minds of whether, if it's suspected, do we need cross-sectional or is ultrasound enough? So let's see how good ultrasound is. Well, when comparing it to the surgical product or results, for gross ETE on histology, you can see here that the sensitivity is about 78% in this series by Lamartina, which is pretty good, but that would suggest that about 20-some% of patients are still being found to have positive nodal disease after the initial surgery or unexpectedly during the initial surgery. The specificity is very good, and you can see that the negative predictive value is still in the high 90%. Here's another paper, includes Lamartina on it in the World Journal of Surgery in 2020. And here they talk about, well, what is the sensitivity of different definitions of extrathyroidal extension on ultrasound? And they list it as non-restrictive, restrictive, very restrictive. And I think that if we consider anything that even slightly could be ETE as a sign of it, which would be non-restrictive as defined in this paper, and they define that as a nodule abutting the thyroid capsule, even if there's no obvious disruption, or if it disrupts that capsule and has obvious invasion of the soft tissue. By using that least restrictive definition, we find that the sensitivity is 86% in this series. But the difference between this paper and the last is that they're talking about minimal ETE that's seen microscopically. And in this patient series, only 2% or one patient had gross extrathyroidal extension. So as you can see, as these two papers back-to-back kind of illustrate, that it's hard to report on the usefulness of ultrasound for ETE when there's not a widely, firmly established definition that's going to be clear from the literature. But when I take a step back and look at it, I think minimal ETE on many different studies have been shown that there's not a huge impact on the overall, outcome prognosis of the patient, and whether that upgrades you to a total thyroidectomy because you need to get radioactive iodine, I think is arguable. And so I think for our purposes, we should really focus on the ability of ultrasound to pick up gross ETE. One more example that came out of UCLA with Dr. Ye and our trainee Eric Kuo, who's now a fellow at Columbia. They also looked at a similar thing at UCLA. We looked at 36 patients that could have a lobectomy. We again used that kind of very liberal definition of ETE, just any nodule, even abutting the capsule. And with that, we were able to capture the actual ETE based on histology with 100% sensitivity, but with a very low specificity of 36% and positive predictive value of 51%. So what does that tell us as well? Well, when counseling the patient, if we're going to use this very kind of low restrictive definition of ETE, I don't think we should set firmly the surgical plan to upgrade a patient from thyroid lobectomy to a total thyroidectomy based on our ultrasound findings alone. I think that the counseling should be dynamic in that when we think we see it, that it's actually there about 50% of the time. So you may want to let your patients know that we can plan on doing a lobectomy or a total depending or find the OR. And if it's negative value is 100%. So if you think that there is no ETE on ultrasound, on surgeon ultrasound, then you can comfortably reassure the patient that you're going to stick to the plan of doing thyroid lobectomy and not upgrade to a total for that reason. And that brings me to that another fine point, which is that there's going to be a difference between who is doing the ultrasound. And I know that is a little bit of tooting my own horn because I'm a surgeon, but I think we get the benefit of not trying to look around at everything and only focusing on the fine points that will change what we do in the OR, which I think it makes it a little better for that. And there's a lot of user dependence for ultrasound findings. And you can see here that in this paper of 136 patients, when looking, I'll come back to the ability for us to assess lymph nodes on an ultrasound in a second from the same paper. But if you just look in the highlighted box where they talk about muscle invasion or extrathyroid extension into the straps, that at least out of this 100-some patients, 5 actually had ET on final pathology, and none of the ultrasounds before it got to the surgeon where they pick it up. But 100% of those were seen when the surgeon was doing the ultrasound, trying to plan for surgery. So I think that adds another level of complexity when thinking about these studies as a whole. And those studies that I had mentioned previously that had a lower sensitivity in the 70s or 80%, think that there's a mixture of pre-consultation ultrasounds in there. And if we look strictly at the ones done for surgical planning, the numbers may be different. So let me move on to talking about how we use ultrasound to look at lymph nodes as well. So here's a study comparing ultrasound and CT, but for right now I'll focus just on ultrasound. It's a systematic review meta-analysis, 700 patients and 9 studies. So how good are we at picking up nodal involvement with just ultrasound alone, no cross-sectional imaging? And I think that for the most part, that's what we use at UCLA. So looking here in their paper, again, the sensitivity is lower than I think what we'd expect. But again, there's a mixture of surgeon, non-surgeon performed ultrasounds. But they found that the sensitivity of lateral neck disease was 71%. Again, surprisingly low, thinking that 30% of those patients ended up having lateral neck disease that was not seen in initial ultrasound. Even lower for central cervical lymph nodes at 38%, also surprisingly low. But I think for the central neck, the relevance is a little bit lower because whether we need to do a central neck dissection as a part of the initial surgery is also that information is readily available to the surgeon because you can just look at and feel those central neck nodes once you're performing the surgery. Going back to this same issue, looking at the amount of lymph node involvement, again, if you compare in the pre-consultation ultrasound to the surgeon-performed ultrasound, in the surgeon-performed ultrasound, they're able to pick up all of the lateral, the large central neck nodes in those studies, as well as the lateral neck nodes. And only a small fraction of those were mentioned on pre-consultation ultrasound. So especially for looking at lymph nodes, I think there may be an issue of simply not looking very hard for them in the ultrasounds that are done before the diagnosis is made. All right, so those were about choosing the extent of surgery. As I go talking about the cross-sectional platforms for imaging, I'll talk about whether there's added value of CT MRI, but let me take a moment to talk about doing a vocal cord exam with ultrasound. So I think there's been a lot of excitement about looking at the vocal cords with ultrasound as you're doing your neck ultrasound as a surrogate for laryngoscopy or as a way to help some patients avoid laryngoscopy if you can get the view. Now, if you look at the largest series, usually out of Asia, Singapore, you can see here that when they've done 1,000 cases, they're comparing in the box here 3 different things. One is just going clinically based on who is hoarse and who isn't. Another one is this VHI inventory, asking about changes. And lastly is doing this transcutaneous laryngeal ultrasound. All of these are backed up by actual flexible laryngoscopy to look at the vocal cords. And you can see that when you just go by hoarseness, in that first column, of course, you can assess all your patients, all 1,000 patients for hoarseness. And out of 1,000 patients, they only missed 6 patients who actually had vocal cord paresis out of the 1,000, so 0.6% had a normal voice but actual paresis. When they looked at using ultrasound, then 5.9% could not be assessed, likely because of body habitus or just how their neck was. But they could see it in 94% of patients. And in those patients, they had a negative predictive value of 99.9% for using laryngeal ultrasound. So if you can get the view, I think this shows you that it's reliable for showing bilateral motion, and you can kind of forego the laryngoscopy if you can get it. Again, this is in a patient population with a BMI of median of 23, which may be a little different than the States. And that plays out in this paper by Kendall et al., trying to do the same thing in the United States. And what they found is that out of about 500 patients they tried in, that they could only get a visualization of the vocal cords in about half or 50% of those people. The table is a little bit misleading when they say incorrect correlation versus correct correlation. The big chunk missing are the patients that could not have the cords visualized on ultrasound. So I'll summarize what the point is, that I think it's always worth looking. You just kind of shine your ultrasound directly at the cords higher up in the central neck to see the cord motion. And if you can get it, I think it can spare you doing a laryngoscopy. And we'll talk about the utility of routine laryngoscopy in a little bit. Okay, so CT scanning. So ultrasound, ultrasound, ultrasound for all patients. And I think the majority of patients who have relatively straightforward disease, that's really all you need. But let's talk about when we need to add a little bit more to that. So first, again, the two main things we're looking for to dictate what we're going to do in the OR is extrathyroid extension and nodal involvement. Will the CT help us pick up more extrathyroid extension? Well, this paper, again, looked just at gross ETE into the trachea or esophagus in a series of cases of locally advanced thyroid cancer. And you can see that even with routine CT, that the sensitivity is really low for tracheal and esophageal involvement. So maybe a little dubious about how much added value you get out of CT scan. Again, coming back to this paper, meta-analysis looking at CT and ultrasound for lymph node involvement. This study, and I think it is shown in many studies in this meta-analysis, that you do get increased sensitivity at the expense of some specificity when you add CT to ultrasound, and they're able to pick up another 20% of neck disease. Again, though, I'm still a little bit skeptical because of how low the sensitivity was for ultrasound picking up nodal disease. Certainly, I think that has not been our institutional experience, that we miss so many nodes. And if the rate of nodal detection is higher in ultrasounds done after diagnosis is made, maybe there's even less value in adding CT. You can clearly tell that I'm biased in that regard. Looking at the central nodes, that there is obviously still added value in doing CT, but again, when it comes to being in the OR, I don't think that surgeons really need a CT telling them that there's going to be central neck nodes to guide them to do a central neck dissection. Looking at UCLA, kind of want to break it down in our practice. I'm sure many practices that see a large volume of thyroid cancer and high prevalence of thyroid cancer. This is what you get as a final product based on that meta-analysis of those 9 studies, that if you add CT, you would add about 9% of negative predictive value for lymph node involvement, but you also call 10% more nodes that wind up to not be nodes. I think that that's probably a worse trade-off for us, the fact that you get another set of imaging and you end up doing more node biopsies or workup based on E2. So when do we use CT scan? I think that we use it when the neck ultrasound reaches its limits of its boundaries that we can image. So if we see nodes kind of going into the mediastinum, beneath the sternum, under the clavicle, we'll usually get a neck ultrasound. If there's really extensive nodal involvement going really posterior to a place we're not used to looking in level 5, high level 2, of course, for any revision surgery. And if there are other hospitals that don't have access to high quality ultrasound, or there's no ultrasound available for you to do it yourself in clinic, then I think a CT scan is warranted in those situations. All right. What about the iodine? I know that sometimes we always, another reason why we don't use it as much at UCLA is I think, kind of gives our endocrinologists a lot of anxiety about what about the ability to give radioactive iodine if needed afterwards. So I think we were less worried at Memorial, and so I wanted to look into this. So there was a publication 2014 where these researchers looked at the amount of iodine in the urine after a patient gets routinely preoperative CT scan with IV contrast. So it ended up being 1,000 patients. They got their preoperative CT with the standard amount of IV contrast, which has a ton of iodine, 24,000 to 30,000 milligrams. It's like 600 times the amount you're supposed to have each day on a low iodine diet. They get their surgery. They are asked to do a low iodine diet for a week before we take these measurements. And then this is what they get. And so they stratify the patients based on when they were planned to get the rate of iodine. So some patients were in this 30 to 60 day range where they got the CT scan 30 to 60 days ago and extends out to about 6 months. But you can kind of already see based on this scatter plot that no matter whether you're a month out from your CT scan or 6 months out from your CT scan, the amount of iodine in your urine kind of coalesces around the same amount. The dark line, the dark black line from the original paper corresponds to a 24-hour urine collection of about 150 micrograms a day, which they kind of arbitrarily chose as what is acceptable in general to nuclear medicine physicians before giving REI, and don't think that it'll interfere with the therapy. I think digging a little bit more into our current understanding of the literature is that actually anything less than 250 micrograms in 24-hour urine collection has not been shown to adversely affect how you uptake or the effectiveness of iodine. And so you can see that majority of those patients fall underneath that dashed line. And there really is no difference waiting 30 days or 60 days. So I think this gives us a lot of reassurance that if you need a CT scan to make a better operative plan, you can go and get it. It's not going to screw up your radioactive iodine. All right, so MRI. MRI is used even less than CT, but when comparing the two different cross-sectional platforms in terms of looking at ETE, I think I just want to highlight this here, that looking for tracheal involvement, that the sensitivity of MRI in this small series is 100% compared to only 59% using CT scan. And I think that's consistent. The low sensitivity of CT scan kind of bore out in the previous studies that showed as well. Same thing for the esophagus, that the MRI is able to detect esophageal invasion with 82% sensitivity, whereas the CT only found 29%. And I think the sensitivity is really what matters here, because that is ultimately what's going to prompt you to do an endoscopy or bronchoscopy to look inside the lumens before you operate and make a better operative plan. You can always do less, but it's hard to plan for more. So when you do your initial ultrasound, you have suspicion for ET into air digestive structures. I think that this shows you that getting an MRI is going to serve you better than getting a CT scan. So when do we use it at UCLA? We'll use the MRI when we think there's air digestive invasion or in the rare incidents where patients have a contrast allergy. At CT, there's nothing really much to say and no good data that I could really show you. So I just want to make a quick note that I don't really think as much of a role in the planning of initial treatment for thyroid cancer. Of course, there's a well understood phenomenon where if you have an elevated thyroid globulin, but your radioiodine imaging is negative, it just means that the tumor has began to de-differentiate and not uptake iodine anymore. It's lost the sodium iodine symporter, and there's an inverse relationship where as they lose that, they start taking up more sugar. And so things that are cold on radioiodine imaging, but there's biochemical evidence of persistent disease, that's the time that you get a PET scan to help you map out where the disease is for your next phase of treatment. All right, one last quick note about doing a vocal cord examination with laryngoscopy before surgery. So you can see it clear as day when you do laryngoscopy. Laryngoscopy can be done in the office setting, and so when it seems like the transcutaneous image ultrasound is so unreliable in the majority of patients, I think it's always good to try with ultrasound because it's free. If you're already doing it, you're already there. But otherwise, this is probably still the gold standard. But do we really need to do it on everybody? So I think this paper addresses that. This is from Australia. Maher and colleagues, they looked at thousands, nearly 6,000 patients that are undergoing thyroid surgery. And they identified when all these patients underwent laryngoscopy that they only found vocal cord phoresis in like less than 1% of all those patients, 41 out of 6,000. And if they didn't have any risk factors defined as a nodule greater than 3.5 centimeters, pre-existing coarseness, and this also included people who had been operated on previously, that virtually none of those patients had vocal cord phoresis. And so I think if they have no risk factors, then there's no need to be doing it on every single patient that walks through the door. And even when you narrow it down, you can see that that there is still, it does hold true that patients have a normal voice and one nerve out. And so maybe in those patients, then we clearly need a better nomogram for knowing we need to do it. All right, so summarize all that up. Ultrasound, 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 every situation, just I strongly advocate for doing it on your own. We do it, patients will often come with an ultrasound. We'll do another one when we see them in the office because they're in every room. And then we always haul one to the OR. So when we're about to operate, we actually do another one to make sure there's no last minute change in plans. Rarely do we need anything else additional to that. But if we're worried about nodal involvement, get a CT. If you are worried about ET, digestive structures, then MRI is going to be better than CT. And then in terms of looking at the vocal cords, laryngoscopy is not needed for everyone. At least you should limit it to people who have a thyroid nodule that is bigger than 3.5 centimeters or coarse, or has previous operation. But even with that, it's still a very small percentage you're going to actually have a problem. You can probably do better on that front. All right, so that's all I got. Thanks for joining me and listening to all this. I'm happy to answer any questions.
Great, thank you, James. That was really a terrific overview and gave some really great insight in preoperative evaluation here. Let me ask you about your approach to the threshold for performing a biopsy, or whether you do a biopsy in the situation where you have either a suspicious nodule on one side, or if you have a documented malignancy on one side, and you've got a very small lesion in the contralateral lobe. How do you handle that? Will your threshold for doing a biopsy stay true to what the ATA guidelines are, or TIREDS, or will you lower your threshold to get an answer so that you can guide your surgery?
Great question. So it definitely lowers my threshold when we're going into the neck, into the ipsilateral neck for any other reason. I think I find myself in this situation less so for patients with bilateral thyroid nodules. Let me address that first. With bilateral thyroid nodules, proven malignancy on one side, if the other one is relatively low risk, I always am my personal bias, I'm always leaning towards trying to do less with surgery than more. And so if the index lesion already is a low risk lesion, 1 or 2 centimeter PTC, the other side looks okay, I tell the patient that it probably serves them better to just avoid biopsy on the other side and still going by guidelines. We can just observe the other side because the planes there will be the same because we'll leave them alone. A lot more important than what I think, though, is probably how the patient feels. And so, I think it's easy to know with your patients if they're really concerned about that nodule and just don't want to observe them. You're already there, so you can biopsy to help you tell you what to do. If patients, trust you and they're okay with trusting you to observe it with ultrasound, and that makes it easier. I think the other situation we find ourselves in is what if we're doing a parathyroidectomy? For us, we do routine four-gland explorations. So we're going to be in both sides of the neck. And then if it turns out that you have to do something for a thyroid nodule, then it's scarred on that side. I think then that's when I have the lowest threshold to start biopsying things, even if they don't fit into those categories, just so I'm not back in that area.
Okay, so just to clarify, I think those are good points here. Just to clarify, you've got what you think is a situation, notwithstanding the parathyroidectomy scenario that you just mentioned, but you have a situation where you're planning on doing a thyroid lobectomy to manage a patient's either highly suspicious or proven malignancy. How would you, so you see that there's either a single or a second lesion on the other side, and in light of the high risk of multifocal disease, you'll still trust your ultrasound findings and not do a biopsy on that other side?
That's right. That if they're looking at their side and either it's below a centimeter, I guess to really parse it out, if it's below a centimeter, but looks really suspicious, got calcifications, it has a regular border, then sure, then I'd have kind of a lower threshold to go ahead and biopsy that. But if it's a larger lesion, let's say 3 centimeters, but low thyroids because it's completely spongiform or completely cystic, something like that. In those situations, then I would hold tight to not biopsying those. But again, I would kind of talk the patient through other options and let them guide it more than what I tell them.
And if you were to try to give me an estimate, do the majority of your patients um, want to know before going in for a thyroid lobectomy? Do they tend to be anxious about the presence of nodule on the other side and the potential risk of future surgery to remove that?
So my personal belief is that a lot of the patient's anxiety probably is like a mirror reflection of how you set the stage and tone. I will say that the overall tone I set when I meet with patients is that most thyroid nodules are okay. Um, Everything is going to be kind of manageable, and so unless they walk in the door with a lot of anxiety already, I definitely think I'd probably reduce it more than add it. And for the patients who had a lot of anxiety, they probably have already had multiple biopsies of other nodules before they even see me.
Okay. Um, Great. Can you comment a little bit on your own experience in picking up subtle vocal cord um, 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 movement disorders, meaning that you see a little bit of asymmetry in the movement on fiber optic, how well you can detect that on ultrasound?
Yeah, so I can first start off with just acknowledging my own limitations, even with laryngoscopy. That anything fine, I'm probably not detecting. I'm just detecting like really gross immobility. And when it comes to transcutaneous laryngeal ultrasound, I would say that some of the surgeons at UCLA kind of look at it routinely. I typically don't even try because I just don't trust myself doing it, just because I'm not very practiced. And for me, I think it's just more a relationship of my comfortability with just reaching for a scope if I think it's necessary.
Great. So Dr. Gonzalez from Mexico raised the question of what extent of imaging do you do if you have that unusual case of a papillary thyroid carcinoma identified in a thyroglossal duct cyst?
I think that the ability of ultrasound to image like the central neck, especially getting over the thyroid cartilage, and hyoid is so poor that I would advocate for routinely getting cross-sectional imaging in that scenario. I think a big question mark, and actually something I've been actually wondering about, is what is the uh, where did the lymph nodes go if there is a cancer in the midline? And did they go any higher than traditional, like level 2, 3 that we think? So because that's a big unknown for me, I would just say getting a CT is probably the safer bet.
Okay, all right, terrific. And then just one more question here. Your threshold for doing fiber optic laryngoscopy in the patient who's had any previous neck surgery, obviously a previous thyroidectomy or perhaps a parathyroidectomy, will you evaluate the vocal cords in all of those patients, or will you adhere to symptoms and for evaluating the larynx?
Um, Thanks. So I think if it's coming from an outside surgeon that I'm not able to talk to directly or I don't know well, I think that I will almost always do a laryngoscopy before a reoperation. I will ask the patient if they had any trouble swallowing. It's always hard asking them if they had voice changes because, as you know, almost everyone will report some voice changes after any surgery. So I really focus on whether they had any coughing within liquids, things like that. I think one major difference is that we also have heterogeneity in how we use nerve monitoring, where I use it routinely and some of the other surgeons usually don't. But I think it would give me a lot of anxiety to be in a reoperative field to set up to start, trying to get stimulation of the nerve and not be able to get a signal. And so because I do that, I think it becomes even more important to me to know the status of vocal cords going into that operation.
Great. So let me ask you, we've got a number of other questions coming in. James, hopefully we didn't lose you here.
I'm still here.
Oh, okay, great. Dr. Rhoda Coben from New Jersey raised the question that for surgeons doing ultrasound themselves compared with a tech doing and a radiologist reading or an endocrinologist trained and certified doing in the office without causing any political unrest here. Can you comment a little bit just in terms of, I think you covered some of this in the very beginning of your talk, but any comments on differences here?
Yeah, so clearly I think that there is a difference in the sensitivity of the ultrasound for those things that I kind of harped on that will change surgery. So the extent of extrathyroid extension, whether you need to do a total thyroidectomy for that, or whether there's lymph nodes involved. And I think there's a big pitfall in patients who are just going for a generic neck ultrasound when the tech is trying to look at all structures of the neck and not doing careful mapping of the lymph nodes, that they're going to miss pathologic nodes that you can see on ultrasound. In terms of political, I think I can only speak to our institutional experience, which is that we want to protect the patients from getting excessive charges. And so from a practical standpoint, at least in the States, at least for our practice, patients are not allowed to have more than one ultrasound every 30 days. So if there's been an ultrasound by radiology that's within 30 days, we make note of that. We make sure we don't bill for the ultrasound we do. We still do an ultrasound on everybody because we want that extra information, but we don't risk the patient getting extra charges by billing for it. And I think that's really what the radiologists want anyway. They also understand that we do a lot of ultrasounds, and I think they're okay with that.
Great. Dr. Gonzalez, again from Mexico, raised the question of the extent of imaging that you will do and what type of imaging in the patient who has an incidentally found thyroid nodule in the workup or perhaps surveillance when a patient's got another malignancy that's been either treated or is going to be treated.
Hear you. So yeah, the whole area that I didn't really touch on, but what do we do with thyroid nodules seen on CT or PET scan that are PET avid that get referred to you? I think it kind of just defaults back to we always do ultrasound. So even if something's PET avid, it's been biopsied, we know what it is, I think we'll still put an ultrasound on that patient just to get a better sense of what's going on. Beyond that, I don't think that there's anything special about additional imaging that you would need for incidental thyroid nodules aside from just ultrasound.
Great. And I believe this is our final question. We're going to let you go back to bed here, James. The question from Dr. Chen in New York related to surgical planning for patient in terms of the location of a thyroid cancer that is diagnosed and how that affects your planning and perhaps even your pre-op workup.
Also great. So that's another big benefit of ultrasound over any of those other modalities is that you really map out where the nodule is. In terms of how it affects management, I think clearly if there is the nodule extending outside the capsule, outside the posterior border going to the tracheoesophageal groove, that of course is signs of thyroid extension. In those patients, you kind of plan more for total thyroidectomy than a lobectomy. I think a nodule being very posterior and close to TE groove also raises my threshold for doing a laryngoscopy to look at the vocal cords. Definitely that changes. Aside from that, I don't think we put a lot of weight into whether it's in the superior lobe or inferior lobe, anything like that. It's really just its relationship to the recurrent laryngeal nerve and whether it's coming up the capsule.
Great. Well, listen, I want to thank you again for getting up so early on the West Coast and giving us a wonderful and highly educational presentation this morning. I'd like to encourage all of our listeners to join us again next week. And just a quick plug for 2 weeks from now, we will be conducting our bi-monthly, I think it's bi-monthly, every other month, International Thyroid Tumor Board. And the presenting institution will be Institute Gustave Roussy, and Dr. Hartle will be presenting 3 really interesting and challenging cases from Paris. So thank you all very much for joining us. I hope everybody has a great and a very safe weekend and look forward to seeing you again next week. Thanks again, Dr. Wu.
Thanks a lot. Have a good day.
You too.